A very good morning, dear doctors, dear students, and to everyone from the profession. Warm greetings to you on behalf of Team DentistChannel.Online. A very warm welcome to all you lovely people who've joined us on the 8th day of the biggest virtual implantology event of 2020. Ladies and gentlemen, my name is Ruben Lobo, and it's my honor, my privilege, and a very happy thing to inform and to invite our next speaker, rather the first speaker to start with the 8th day, my very own, our very own Dr. Hemang Zala. Dr. Hemang Zala, ladies and gentlemen, most of you all know is that go-to dentist, that humble dentist, and that person who will always be there for you no matter what. A short introduction about our speaker, Dr. Hemang. Dr. Hemang Zala completed his graduation from Government Dental College in Jamnagar and completed his master's from CDSR, Ahmedabad, Gujarat, India. He has over 20 years of clinical experience in dentistry and owns a private clinic in Ahmedabad. He has also mastered the course of dental implantology and has attended various workshops from Bangkok, London, Boston, Singapore, California, Croatia, Vienna, Rome, Italy. He later honed his skills following the interest in short implants and has contributed enormous work in the said field. He has also conducted and organized various hands-on training sessions and live surgeries to further impart his experience, as well as his expertise. He has a passion for simplifying difficult subjects and concepts and has shared his knowledge being a speaker at numerous conferences. He is constantly reading and upgrading in his free time and motivates students to do the same. Despite having such a vast amount of knowledge, he is humble and down-to-earth person who is just a call away and is never shy of sharing and imparting his skills and techniques to practice the right dentistry with utmost welfare of the patient. Ladies and gentlemen, presenting to you Dr. Hemang Zala live on the 8th day of the biggest virtual implantology event. Dr. Hemang Zala.
Thank you so much for your lovely introduction. And thank you all the participants for joining me on the Monday morning. We'll quickly start our topic, short implant. We'll have a long talk on the short implants topic, right? So the content of uh, my presentation is simple, highly predictable, osteophilic, well, your bone will love this, risk-free and time-tested. This title itself will give the introduction to the presentation. The content will be: what are the short implants? Is the crown to implant ratio important for survival? How do they work? Importance of connection. Are they necessary? Are they reliable? And if time permits, we'll have some clinical cases with some conclusion. So what are the short implants? Now, initially when the implantology started doing dental implants, they used to go for the highest level of length of the implants possible. So at that time, the 13 implants were also the short, considered as short implants. After a few years of their practice and everything, they came to know that they don't have to go very deep into the bone. And with the experience, they came to know that even the 10 implants are enough for the restoring the mandible and the maxilla. And you will find so many literatures of different length, and there was no guideline about the short implants. So the the latest European Association of Dental Implantology in 2016 approved a classification by Olet et al., which says that any dental implant which has infrabony length of design infrabony length of 8 or less and the diameter of 3.75 or greater is considered as a short implant. So this is a definition of the short implant according to literature. And there was one add-on where the infrabony length of the implant is less than 6 it is considered as ultra short implants. So other common terms which we regularly use are wide implant, which are greater than 5 in diameter, narrow, which is almost 3 to 3.75, mini are less than 3 in diameter. The standard are 10 to 13 in length, The longer are more than 13 mm in length. The short implants, as I said, is less than 8 mm, and ultra short is less than 6 mm. So let's come to the first topic, which is crown to implant ratio. Now, what comes in your mind when you see this X-ray? The most of the people will say that uh, maybe this implant length and the crown length is not of proper perfection or proportion, and the crown to implant ratio is not in a good position, right? This all things comes in our mind because we have studied crown to implant ratio in our basic dentistry. This is our base where we say that crown to implant ratio should be 1 is to 2. So if the crown size is 1, then we have to at least have a 2 double the size of the root. If the crown to implant ratio is 1 is to 1, the prognosis of the tooth is poor. And if the crown to implant ratio is 2 is to 1, then the implant, or sorry, if the tooth prognosis is very poor or it's hopeless. So if we apply the same principle over here, the implant to crown ratio is more than 1 is to 2, right? But implants are not teeth, and we should say that we should not consider all the principles of our tooth to the implant. So there are three basic difference which I'll tell you. The first one is this tooth is in disease while this implant is in good health, right? So if you consider tooth in a disease, there will be continuous inflammation, and the disease will progress, while here there is no disease. The second, the surface area of the root which is been left inside the bone is very less than the surface area of the cylindrical implant, which the tooth is usually a conical shape. So the surface area left in this area is very less than this area. And the third and most important thing is the tooth is attached with a periodontal ligament, while the tooth over here is osteo-integrated. So there is a huge difference when the tooth is attached with the bone in a periodontal ligament in between a shock absorber, we say, and here it is an osteo-integrated. So it's like tooth is in a soil, a pole in the soil, and the implant is a pole in the concrete. So it is very difficult to remove the pole which is being fixed inside the concrete, while it's easier for you to remove the pole which is there in the soil. Similarly, one more example, if you have to extract a tooth which has periodontal ligament, it's quite easier for you to extract. You can use any of your periodontal and extract the tooth. While the same tooth, if there are no periodontal fibers, it's an ankylosed tooth, then you should understand how difficult it is to remove the tooth. So the crown to implant ratio, the guideline of which we use for the crown to root ratio should not be applied for the potential site of implant or existing implant restoration. So now we come to our main topic, how do they work? So the biomechanical rationale behind the use of short implant is that high stress value occurs in the crestal portion, whereas little stress is transferred to the apical region. So the more stress is being transferred to the crestal part of the implant, where the apical and middle third has a very little stress. So what other finite animal analysis suggests that almost the 5 mm of 5 top mm of the implant, means upper crestal 5 mm, has the maximum stress level. So if we consider our implant's biomechanics, there are three types of forces: the compressive, tensile, and shears. The implant and bone are regularly loaded with all the three forces, but the bone is more favorable for the compressor force, and the tensile and shear is the worst force or non-axial force. So imagine implant having a compressive force, it is well adapted and it is well tolerated, while the non-axial forces have a detrimental effect on the implant. So this is an imagination. You have to say that this is the bone and you have placed an implant over here, and this is a crown. So if you have a non-axial forces, right, and what will happen is your implant will try to rotate from here, from its fulcrum, to dissipate the forces which has been given here. In doing so, the bone over here will absorb the pressure and dissipate the forces, right? But if you see this area, the blue area, it's an unused area where the forces are not being directly applied from the implant to the surrounding bone. So we can say that it's a blue unused area, right? Now imagine we have a long implant because we have very good amount of bone over here, and the same diameter implant we are using, the same amount of force we are giving it. Again, the implant will try to rotate from its center or fulcrum area, and the bone will get the compression, or it will try to dissipate this force the same way in the crestal part, and the same in the opposite side, the apical part. And what we see over here is that we are just increasing this blue area or unused area if we increase the length of the implant, right? So increasing the length of implant does not reduce the stress along the implant. This is what the study suggests. The implant diameter is more efficient than the implant length for dissipating stress because the area receiving the maximum efforts in the bone is the bone crest, and very little is transferred to the apical portion. So this is logical that we have the more forces on the crestal region. So the crestal part, we have to increase the surface area. So how we can increase the surface area in the crestal part is by increasing diameter, right? So increasing the diameter of an implant by 1 mm will increase the surface area from 30 to 200% depending on the implant design. So if you increase the diameter say from 3.5 to 4.5, it will increase the surface area from 30 to 200% depending on the design of the implant and how the grooves or threads are, right? And if you increase the surface area, obviously the force is gonna reduce. The stress is force upon surface area. So if the surface area is increased, the stress will be decreased to the bone. Strain near the crestal bone area reduced almost 300% due to increase in diameter as compared to 165% reduction to increase in the length of the implant. So here I have mentioned all the articles which we have taken the reference from. Uh, so if you increase the diameter, it can reduce the stress up to 300%. In the same implant, if you increase the length, it will decrease the stress by only 165%. So the 300%, or we can say the crestal stress is decreased less, decreased more by the increasing diameter. So imagine if you have to uh, marry a girl or find a girl today, you can choose any one of either slim fit or a wider, which will give you less stress. But if you have to choose an implant, a short implant especially, choose a wider implant, right? So wider implant will is the wider implant will solve the issue of our less length. The answer is no, because short implant is a bioengineering. We can say it's an engineering marvel, where you have to design an implant in such a way that all the prosthetic forces coming from the occlusal are nicely transmitted to the implant and in the surrounding bone, so that bone remains healthy. Our main purpose is the bone remains healthy and the surrounding tissues remain healthy, and all the stress is been nicely transferred. So we have to consider so many things about implant design, bone, and prosthesis for the short implants, right? So if we see the implant design, I'll just quickly say about few things about surface area, thread design, platform switching, implant abutment interface, the bone quality, and we'll talk about process printing and prosthetic materials if time permits, right? The surface structure or surface of the implant, first topic. The smooth machine surface, if you see the older literature where they have shown that high amount of implant are failed, where short implants had been used because they were all machine surface. Nowadays, most of the implant which are available are rough or textured surface. The smooth machine surface are being used for basal, which has a different indication and different type, right? So increasing the surface texture or implant surface area can be by subtractive process like blasting, etching, and oxidation, or additive process like titanium spray, hydroxyapatite, calcium phosphate ion deposition, etc. Right? The rough implant offers extensive area for osteointegration. It increases surface area or bone to implant contact and surface area. It also improves wettability of implant surface, where it induces the faster healing. Right. The second part is implant microgeometry, or we can say implant thread. The implant can design can be either a cylindrical or taper, but right now we are dividing it into two different parts. It's a screw type implant and the press face implant. So the screw type implant are the implant where there are threads on the implant, and you do one size smaller osteotomy, and the screw type implant will fit into the osteotomy when you turn the implant or rotate the implant into the osteotomy, right? The thread type implant, you have several designs, whether it's V shape, square shape, buttress, skewer buttress, like V shapes, out of which the square has the maximum surface area. If you're considering the short implant, we are always looking for a better surface area, so that we have a good stress distribution, right? But if you see the press fit implant, we have two more design. It's a horizontal plateau, or it's a fin shape design, and the second is sintered porous surface implants. The press fit implant are most successful short implants, which has a good history and a big literature supporting it. So there are two differences between the screw type implant and the press fit implant, which makes it successful, which makes press fit implant successful in the short implant. The first of all is the surface area. So for threaded implant and press fit implant, the press fit implant has 30% more surface area than the threaded implant of the same design. So there are certain articles or studies being conducted, which says if this is a 5 by 8 implant of all the companies, the press fit implant has the maximum surface area out of all other implants, right? So again, we come to the same point. The more the surface area, less the stress, and the force is nicely been distributed to the surrounding bone. The second most different between the threaded implant and the press fit implant is, people are not talking about this, is a differential healing, right? So imagine we have two implants. One in the right side is the threaded implant, and here it is a press fit implant, right? So in threaded implant, we do a osteotomy, one size smaller usually. If the bone is very soft, we do it two size smaller. Then we apply the torque and put the implant in the proper place, right? So what happens is the implant pushes the bone, surrounding bone, and it squeezes, and there is a primary stability which holds the implant into the place, right? So in doing that, we give some pressure to the bone. While the press fit implant, they usually are placed by tapping the implant into ostomy. So if you want to place a 4.5 by say 8 mm implant, 4 by 5 is a diameter and 8 is a length, you create the same type of osteotomy, the same well of the osteotomy, right? And then you press fit the implant in that position. So what happens over here, that your implant is not squeezing your bone, right? You can see these chambers over here, right, where the blood will immediately fill the area which is vacant over here or voids over here, right? Now second stage comes where because of the pressure, we know all the in the orthodontic we have seen, where there is a pressure, the bone will start remodeling from here, and there will be bone resorption. So from here the osteoclast activity will start and bone resorption will start, or we can say the sigma phase of the healing will start. Over here at the same time, the clot formation has already occurred, and the new bone formation immediately starts. The osteoblast starts their function immediately over here. So in the press fit implant, there is a difference, and here there's a difference. And at the last, the bone deposition starts with the threaded implant, and it is now been holed with the new bone formation, which is called apposition bone. Right over here, the bone formation is much faster than the threaded implant, because there was no osteoclastic activity as such to begin with. So the here the bone is a different quality. You can see this holes over here. It's a live bone, or we can say it's a callus type of Haversian type of bone, which we can get in the this type of differential healing in the press fit implant, while here we have an opposition type of bone. Right, the mechanical stability will decrease in threaded implant. The mechanical stability will decrease to replace by development of biological stability. Biological stability is which we get after the healing process. Well, there is a opposite today. The biological lower initial stability will normally increase with the time due to lower mechanical stability being reinforced by the bone remodeling. So the press fit implant, you will not get the primary stability, but over a period of time it will increase because of a differential type of bone healing. Right here we have faster bone formation than the uh, threaded implant. So for the press fit implant, the two-stage protocol should be followed for the implant restoration. So you don't have to go for immediate loading whenever you are using the press fit implant or shorter implant or press fit implant, right? Now we come to the second part, is the bone quality. Now density is directly proportional to the strength. The D4 type of bone is 10 times weaker than the D1 type, and the resultant force is again the magnified in the softer bone. The lesser dense bone demonstrates reduction in strength by 50 to 80%, as we all know, right? But what we have seen is the higher degree of mineralization occurs around the short implants, especially in the crestal region. So if you can see this X-ray of ours, all the X-rays which you will see in this presentation are mine, and mostly at least 5 or 6 years old or more than that, right? So you can see this whole white area over here, especially above the neck of the implant, is being highly mineralized, right? So with the time and function, the cervical third area over here is been densification occurs because of constant stimulation of the bone. And this transformation is because of the Wolff's law, which has been given in 1892 by a German scientist, and which says that every change in the function of bone is followed by certain definite change in its internal architect and external conformation, right? So this bone stimulation theory is very helpful for the short implant, which will always help to hold your implant for a longer period of time, and the osteoblasts around the implant will stimulate with the constant pressure or stress given on the implant, and which will start the remodeling of the bone. So if okay, for the poor bone, we always suggest in the maxilla, if possible, you use the sinus cord for by cortical fixation, right? Now we come to the prosthetic consideration. So this is very important to know about the connection of your implant. Implant abutment connection is the part of the implant, the connection over here, where the abutment is been fixed inside the implant. So we in all the two-piece implant, the abutment connection is the most important area or the crucial area where from the prosthetic forces are being transferred to the implant, right? So we have given a classification. This is I just if you want to go to detail of this implant abutment connection, there is another video of us where the connection has been nicely understand. But I'll just go through this very quickly. The right now, if we consider external connection and internal connection, external connection we are not considering because most of the company has internal connection. There are three different type of connection. We can say the butt or slip joint fit, where the implant and abutment are passively fit into each other. So all your hexagonal and octagonal tri-channel implants comes into this type. The most taper are cone within a cone, where 1.5 degree taper abutment fits perfectly well in the well of the implant, and it causes a cold well seal. So there is no micro movement or there is no micro gap between it. The conical is a hybrid between the slip fit and the taper implant. So there is some amount of the conical connection or most tapered type of connection, and followed by the slip fit. So there is some micro space still there present in the conical connection, right? So what the study says that average micro gap between implant and abutment junction has reported from 1 to 49 micron. Now, as I told you, the slip fit has the maximum micro gap, the conical has medium, and the most taper has the minimum micro gap between the implant and abutment junction. So, if you want to go through this, there is an videos of Ziprich where it has been very nicely demonstrated the implant abutment and micro gap and the movement which is present because of that, right? So if we have this is our mechanical problems with the micro gap, the micro motion, but right now we are more concentrating on the biological problem at this topic. So the bacterial size of the bacteria are between zero point 0.5 to 2 microns, we can say, and this is sufficient enough for them to stay in the micro gap of the implant abutment junction. Now, if we consider again, the slip fit has maximum space, while conical has second number, and the true most taper will have only 0.5 mm of the space between implant and abutment. So, virtually the bacteria growth cannot be happen in the most taper or connection. I'll just quickly go through the slides over here. The dynamic loading, with the dynamic loading, the size of micro gap increases because of micro movement. The size range of micro movement is from 1.5 microns to 94 microns. So imagine there is a micro gap, and if you give a load on it, the implant and abutment, there will be some micro movement along the implant abutment junction, right? So what happens now, that bacteria grow in this micro gap, and with the micro motion there is a pumping action where the exudate from the bacterial endotoxins will start pumping towards the peripheral area, right? So the micro movement causes micro motion, and with the micro motion the more micro gap will be available, and the bacterial endotoxin will start spreading towards the periphery of that area, right? So a micro pump will be there, and which each movement the exudate will come in and go out from that area, which causes inflammation in soft and hard tissue around it. So in the vicinity of that area, there is always an inflammation in soft tissue and hard tissue, which causes the bone loss, or with the vicinity, or we can say it, an area of toxicity around implant abutment junction, which is the main reason for the crestal bone loss, or we can say the first thread bone loss, which is seen in all implant abutment connection or where implant design, and which is sometimes considered as a normal after the loading of the implant, or we can say the first year there is almost 1 of bone loss around the implant abutment connection, right? But this is not favorable if we see for the short implant, right? I'll just again quickly go through all slides, right? So imagine a case, right now we say that all of implant should ideally be at subcrestally at least 1 or 2 subcrestal for at least for short implant, and all the other implants also, if you have a soft tissue less than 3 you should place at least 2 subcrestally. Now there are certain benefits of placing the implant in the subcrestal region, or if you bury the implant, you have less micro movement, adequate amount of crestal bone thickness, the minimizing crestal resorption, and that. Right? So imagine if you have placed an implant subcrestally, you load the implant, and the force, the dynamic movement of the implant abutment junction, you will start getting the bone loss over here, and within a year or so you will have a first screw exposed. So this is very detrimental for the short implant. So if you have a longer implant, say 10 or 12 you have 1 of bone loss, it's not a big problem because you have so much length of the implant left. But if you consider that for a short implant or ultra short implant, if you have a 5 mm implant and you have 1 mm bone loss, you have almost lost 20% of your implant surface from here there only. So for short implant, always preferred and most taper connections like this. So if you have load the implant, you don't have to worry about the bone loss and for the years and years to come, right? And you can see again the same x-ray which we have shown, even after loading for many years you can see the crestal bone formation or even bone creeping over the implant abutment junction. The second part of the process is the whether we should splint the abutments or unsplint. Now, literature says the splinting of short implant, especially if you have a multiple implants placed, the shorter one should be splinted with the long implants. And if you have two implants or three implants placed, the longer implants can support the shorter implants. But what we have found is there is no much big difference. We have almost used one one tooth per implant in maxilla. We are splinted for mandible, and but yeah, yes, people still prefer the splinting of abutments. But if you have a case where you have to just restore only one tooth, you don't have the option of splinting, right? The other thing in the prosthetic is the prosthetic material. There are certain composite material which can reduce the forces, like trinia, which will reduce the load on the implant. If you consider the ceramic or zirconia are hard surface, the acrylic are soft surface, the composite are in between. They have quality of both aesthetics and strength, and it will reduce the pressure on the uh, implant. Now we come to the most important part of are the uh, short implant necessary, right? Uh, the study says almost 50% of patient which we have minimum bone length available. Now in your case is when we started our practice of implantology, soon we came to know that most of the patient we have very less length, and from 2006-7 we then shifted to short implants, which has given a good success in terms of solving the problem with the less height, right? So if we consider the anatomy, we have the mental nerve, inferior nerve, nasal cavity, maxillary antrum, out of which the inferior nerve and the maxillary antrum are the most important places where we need to place in short implants, right? So imagine if we have a case like this where you have very less height of the bone, what options do we have, especially restoring the posterior region, mandible, and the maxilla. So even the mental nerve and the maxillary sinus. So grafting is the one solution. But if you think about grafting, you have to think about the price, the morbidity, the amount of surgical expertise you need to have, the time duration, and after doing all this hard work, you have to still consider, the luck also, whether the tissues or the bone graft which you have placed is going to convert into the natural bone and is going to help your implant to sustain for a longer period of time, or the distributed stress, or it's just a white opaque material which is being shown in the x-ray. You have to consider that either it's a biological bone which has been formed or not, right? So studies always suggest that the short implant is more viable than you can go for the sandwich bone graft or all other procedures, right? The other options right now available are no transportation or no bypass. People also think about using a longer implant and trying to bypass with the tilted implants. These are options, but the shorter I feel is more simple, and most of them is more easier and less risk, right? So you can see these implants, they are well integrated, they can be used very nicely. Over here you can see the nerves passing through. You can easily place in short implant for one case, single individual implant, and instead of going for nerve transportation, literation, or bone grafting, can place uh, the short implants. Even for maxilla, you can avoid sinus lift. Over here, you can see the sinus lining here, and you can. Uh, this is a case which is more than 7 years. It's been single tooth. There is no tooth over here, but still is functioning well. These are all this sinus lift which we can avoid, right? And I'll just again go quickly over here. You can see this sinus lift. Here we can see the sinus over here, but unfortunately this X-ray does not show the top part. Even here also the short implant is used. This has been buried. The short implant again. So the next question comes is, are they reliable? Now again I'll just show you some cases which are which has been time tested, and there are so many literatures also which shows that the short implant has a equal success rate like a standard implant, and but I'll show you these cases which have been restored at least 5 years or more. So if you see other cases which have been done for 3 years or 2 years, which does not hold more truth, these are all more than 5 years, which has shown that the short implants work equally well for giving support to the uh, your processes. So this is 5 years follow, and these are old slides, so it shows 2012. I have just taken from my other presentation, so it's now more than 8 years old. These are again the same slide. This is again the tooth has been restored. The short implant, the short implant, the mandible. There was a bone void over here, big bone void, and actually because of the failed implant, we have removed a failed implant from here, uh, and then put a short implant immediately, and it was been restored. This is again a good case of single tooth which has been replaced with the short implant 5 by 6. This is the mandible. The nose was very near. This is again a mandible 5 by 6 implant. You see almost all the cases are 5 by 6, or some of the cases are 6 by 5.7 length. This is again 6 by 8 long implant. This is 4.5 by 8. This again implant, the 4.5 implant. These old cases I'm little ashamed to show, because the process at that time we don't have good labs or the prosthetic options. But right now we are more showcasing on the implant functioning. So please ignore the prosthetic part of the X-rays. You can also see over here the margins were not good, but see the implants. The 6 by 5.7 implant is functioning very well, and the mandible. This is 4.5 by 6. Again, the uh, in upper jaw we have not splinted the implant. Now I'll just quickly show a case, and I think we are short of time, but we'll give you a small case demonstration. Two cases. Uh, this was in 2007, where and a young lady of 40 years of age has limited mouth opening and come to our clinic for restoration of tooth over here, right? At that point of time we were not aware of the no problems which we are going to face. We just discussed about the financial part, and I quickly check everything. At that time we didn't have the facility of CBCT or even RVG. So we decided to place an implant in limited mouth opening, because of she has an OSMF of because she was chewing a tobacco. It's very famous in this part where of Gujarat, where people eat tobacco. So she has very limited mouth opening. And when we started the surgery, I found that it's very difficult to see the side, uh, put the implant and do all this thing. Anyhow, we managed to place the implant, right? So if you see this case, the 5 by 6 implant was used, and it is not in a favorable position. We could have placed little back posteriorly, slightly away from the tooth, we can have submerged well. But anyhow, this was the blunder which we have made. After 3 months of healing time, we put a crown. Again, the crown is overhanging, the margins are not good, and because of limited mouth opening, we had to compromise so much during that days. And the x-rays, even the IOPA was possible, the RVGs were not possible, so it takes at least 2-3 minutes for the IOPA for development, and we can see or check the implant, right? But it went very well, and we see this patient maybe after almost 10 years we saw this patient back. And then we change the crown, but we see the implant is it's in a still very good health. Even the space between this implant and the tooth is less, but it has survived because the design of the implant is a plateau type of design where the bone has grown inside the fins, or we can say between the threads of the implants. So this bone is not an apposition type of bone which is keeping the bone live over here, and the implant is still working, and the crown is still holding up. So here we want to say that the short implants, if you have chosen right type of implant, is going to work very well in almost all the situation. uh, Now we are going to show you another case which is recently done. This is not very old, it's almost 3 years or 3.5 years now, where we have done a step ahead. We have used an ultra short implant in association with sinus lift and in the posterior right maxilla. So it's a 55-year-old patient, diabetic, and has gone with the bypass, so he's medically compromised, and only one tooth has to be replaced. It's at up to 27, right? So if we see the CBCT of the patient, the vertical height is limited to 2.6 to 3.9 mm, and these are the other angle X-ray. Over here we have only 1.9 mm of bone, right? So the native bone of the or residual bone height is almost 2 mm at certain place. Now what does literature says? If you have a residual bone height RBH less than 4 mm in length, you have to go with the lateral sinus lift. Even inter the dynamic sinus lift you should not try, right? So what we have done is over here the minimal invasive transcrestal sinus lift procedure we have used. So we have decided to go the internal sinus lift in this case. We started our osteotomy, and this is actually a parallel beam which we have used to lift the sinus. We have started bone grafting, and after drilling we have placed an implant. We have put a bone graft, a nova bone putty, and push the implant over here. You can see there is no primary stability of the implant. The implant is actually floating inside the bone graft, and we have placed the implant and stabilize the implant in the proper, then we change direction little bit over here and in the favorable position. You can see all this bone graft above the implant. The original bone is still here only. This is all bone graft which has been placed. So the implant is floating inside a say a sac of the bone graft. There is it is not in contact with the any of the natural tissues. Now, all you must have so many questions. The residual bone height is less than 4 mm. There was no primary stability of implant. Implant was placed in grafted non-vital bone. It's not a natural bone. The shear forces between implant and new bone containing graft material, the biological response of physical force that comes later on. So what would happen now? We can I'll just show that implant got osteointegrated very nicely. We restored the implant, and after the for the second part of his tooth replacement, we got the CBCT, and we found that we have got a quite a large amount of bone which has been converted from the bone graft to a new bone, right? So I'll show you this slide. So the ultra short implant, this has been after at least say loading. You can see the bone has been converted from the bone grafting to the new bone. So it is an artificial bone which is now converted into natural bone, which can take all the forces from the 2-7. You remember 2-7 has a maximum, we can say, biting force or the stress coming to it. And so now we come to the conclusion part of the implant, our presentation. The study says the press fit implant is more successful in short implant than the standard or the threaded implant. The threaded implants also work well in most of the cases, but if you consider the short implant, always think there are surface area and the differential healing, the implant abutment junction, which I have already mentioned, that factors which makes different short implants from other standard implants is very important, right? Because the same is the study shows that the short implant with press fit implant and sintered porous surface topography implant, they are endopore implants, which were I think it's not freely available as more surface area. The clinical outcome is almost same, 94 to 95% of survival of same or shorter implant after 3 to 6 years. This is what other studies says. The majority studies obtained of the meta-analysis also shows that shorter implants are reliable treatment option for restoring the tooth, right? Even systemic reviews also says the 99.1% success rate with a shorter implant. So with all accumulated research data and my clinical experience since last 15 years or maybe 17 years, I can say that it's a shorter implants a good option whenever possible. So keep things simple and safe. KISS principle and imagine yourself in this baby. And life is short. All we know about this pandemic, and do all the things which decrease your stress level, right? And think short, the think short implants, right? And I will end my presentation. Thank you, Ruben. See a few questions. I'll just quickly answer a few of them. One of them is, in case of severe pneumatization of sinus, can we use short implants along with internal sinus tip? Yes, we are doing that since many years. And actually, I suggest to go for short implants only. In most of the cases, you get at least 6 or 7 mm of residual bone height, and for that, it works very well, tremendously. People says that posterior maxilla the bone quality is not good for the short implant, but we say other ways that the short implant will work very well. Even the crown root ratio, you don't have to worry so much about it at that place if we have a bigger crown, because most of the time you have posterior, you have to have a longer crown to be replaced, but it will work very well. And for the sake of information, some people also, when I have to interact with the foreign delegates and everything, they use the word vertical cantilever for the crown to implant ratio. uh, but again, I have shown the slides where we have used a longer crowns, or which is more than 2 is to 1, but it works very well, right? The other question was, available bone height is also less. What is width? Yeah. So if you have less width, you are compromised again. You have less length and less width. So you have to increase the width. You have to go with the bone split technique to place the implant. And if you see the time frame for the healing, it will be almost same, because if you do a rich splinting in a proper way, maybe you can say that 2 or 3 weeks or 4 weeks you need a more. If you have planning to start a second phase of the 4 month, you can wait for 5 or 6 months over here and put a wider implant. But wider implant is must. I should say that at least 4 or 4.5 is my favorite. The other question is, short implant can use along with all on four implants to increase AP's spread. Now, all on four is a different concept actually, where you have to place and tilted implants longer by cortical fixation, and for on cross arch stabilization with all the implants, right? If you are using the same concept in the short implant, it is not going to work. Over here, if you want to place all on four implant, you have to use a different type of framework, which is a linear framework. You can use four implants, short implants, and replace the whole arch. But for that, you have a special design framework, the special materials which are being used, and you can use short implants over there and replace the whole arch, right? So, what extent short implants are successful in diabetic and osteoporotic patients? Now, uh, the diabetic patient, I don't feel it's a contraindication for short implant. No, it is almost compared with any implant. If you can place a standard implant, you can place a short implant. So medically compromised, you don't have to think so much about that. What I feel that if you have a press fit implant, it's a you just have to do a good primary closure, because most of the time you have to bury the implant subcrestally and you have to do good primary closure. If you do that, there is no chances of infection, and you will have good results. Some of the companies, uh, right now we are having a scientific session, but there are so many companies which has specifically designed short implants. Bicon, Endopore are few of them. There are few companies which are all coming also. I think K3 has short implants. And but what other things you have to look for the short implants is connection. You have to have a good connection, uh, where you have a good bacterial seal with implant abutment connection, so you don't have the problem later on, because everything is going to osteointegrate. A short implant, long the standard implant, it's going to osteointegrate. It's only after you load the implant, the force will start distributing and you will have a crestal bone loss, and we don't want crestal bone loss in short implant, that's for sure, right? So Ruben, you have any other questions?
Yes, sir. I do have a few more questions. We've
Okay.
got the questions on various other social media. I'll cover them shortly. Uh, since all talk about multi-unit abutments for fixed processes, what are the options with Bicon implants?
See, for Bicon implants, actually they have a universal abutment. Now, what type of process you want to go for? If you mix match it up with the different implant design, excuse me. So, if you have used a shorter implant of Bicon and then a standard implants or other threaded implants in the other places, and where you are using multi-unit abutment over there, then you will have limited options over here, because they have uh, the standard abutments on which you have to go with that. You don't have a multi-unit abutment. Actually, they have a different type of design of abutment which is not available, or we can say it's not more feasible for using with along with the multi-unit abutment.
Thank you so much, sir. Next question. Sir, I used a Bicon implant, and for a Bicon abutment, there was no indexing for dental laboratories. How do we train the dental laboratories in regard to this?
So Bicon implant, if you're using, you have a 360-degree rotation, means you can place the abutment anywhere. Now, if you're taking an implant level impression and sending to a laboratory, I have this difficulty because labs actually are not trained over here to restore the Bicon implants, because it's the only system which has 360-degree rotation of the abutment. So I pour my cast with me. I choose my abutment. I mark that with a say a pen, or if I make a groove over here and make an indexing with the cold cure or patent resin, and then give it to my laboratory. He will design the abutment in such a way now, and then he'll give the resin indexing along with the crown and everything. Now, best part over here is we can do external cementation also. So if you have only single crown, I will like to do external cementation with the abutment and tap that abutment into the place. So you don't have to worry so much about angulation and everything. You have a crown which you can index with the adjacent tooth, and then you can just tap it over there, and it works very well. You don't have extra cement, and you don't have irritation around it.
Thank you so much, sir. Next question. Is your practice exclusively with Bicon implants, or are you using any other conventional implants as well?
See, it depends upon how much, which cases we are doing and where we are doing, and availability also. So, the if Bicon will be my first choice, but again, the affordability and everything we have to consider.
Correct. Next question is relating to that, sir. A country like India is a price-sensitive market. How do you convince your patients? Because I have seen a lot of presentations and Bicon implants are very good. I also wish to somehow do Bicon implants in the near future.
Yeah, that depends upon individual actually, and how basically, I have an old practice. So I started in 2002. So for my patients, I don't have to stress so much about the charges and everything, and most of the time I actually keep away from my patient for financially, and my staff and my doctors help me out with this. So they just explain that there is a solution without grafting, where you don't have to wait so much, and it will have a more better results or equally good results. And the second option is a grafting. But if you consider the grafting and non-grafting option, the price, the lending cost will almost same. If you go with the a specialized short implant, we are actually, this is a scientific presentation, so we are not talking so much about company. But if you think about the bone graft, the membranes which you use, right, the titanium membrane or whichever, the bone grafts are very expensive, so the lending cost will be more than using a short implant in that case. So whatever you charge from your patient, you have to plan accordingly.
Absolutely. Correct. So last question before you wind up. Can you place a Bicon implant in zero primary stability?
Yes. uh, in fact, uh, because the prepared valve is almost same size, and you place the implant, sometimes you will have you can feel the implant moving in that. I have shown the last case where we have placed the implant which was almost floating inside the sinus, right? So it's a little maneuver here and there, and it can move the implant. So there is no primary stability, no primary stability, and still the implant osteointegrate very nicely, and it can restore any tooth in the mouth.